Hello everyone and welcome to the 8th of July. It is a fantastic day. It is slightly cold in some areas, I do believe, and slightly humid in others. Hi everyone, my name is Chrysta and I'm the ACT Chair of the Australian College of Nursing. I'd like to welcome you to our presentation this evening with BEAT Bladder Cancer Australia. In the spirit of reconciliation, I acknowledge the traditional custodians on the land on which we meet this evening and their connections to land, waters and community. I acknowledge the stories, traditions and living cultures of the Aboriginal and Torres Strait Islander peoples on this land and commit to building a brighter future together. I pay my respects to elders past, present and extend that respect to Aboriginal and Torres Strait Islander people who may be joining us today. So just jumping into some of the functions that we can do on this lovely webinar today. There is a questions function in the toolbar. Please feel free to drop your questions in any time. We'll get the organisers on the line and the presenters to jump on those questions and see if we can feed that into our webinar this evening. And also there's a handout section. We've uploaded some information for you to take home and take away, always a good thing. And we have a survey coming out approximately 2 hours after we finish this evening. So without further ado, I will hand over to Dr. Kalli Spencer, who will take us on our journey for this evening. Kalli.
Thank you, Chrysta. I just wanted to see if our two special guests had arrived. We had Professor David Gillatt and Ali Morrice. I just wanted to see if they had joined in with us.
Yeah, I'm here, Kalli. Hello.
Hi, Ali and Professor David Gillatt. Are you there? Maybe he's still connecting in. I have texted just to make sure that he's there as one of our speakers.
He is on the list as being present, but it says that his microphone is currently muted.
Okay. Professor David Gillatt, if you're there, please unmute your microphone, and otherwise I'm going to get started. So thank you so much to the Australian Council of Nurses for allowing us to do this presentation this evening from lockdown in Sydney. I know not everyone is in lockdown, but we are. So thank you for joining us. We want it to be very interactive. We want it to be fun and very practical so that you can take back what you've learned to your workplaces and put it all into practice. So I'm Dr. Kalli Spencer. I am a urologist training based in Sydney. I will just be facilitating the discussion tonight, but we have two experts in the field that join me, and that's Professor David Gillatt, who is the head of surgery and urology and robotics at Macquarie Private University Hospital in Sydney. And then we also have Ali Morrice, who is a urology oncology trained nurse who is from the Mater Hospital in Brisbane. So I'm very, very privileged and honoured to have them here by my side, and they're going to respond to some of the clinical scenarios. So the way we've decided to do this is just to set it around cases so that it's not didactic theory and everyone can be involved. So let me tell you a little bit about BEAT Bladder Cancer Australia, and that's the association that I'm part of and help to get off the ground. And let's see why my slide's not changing. Now it is. Okay. So what does BEAT stand for? Firstly, it's Bladder Cancer Education, Awareness and Support and Treatment. That's an acronym for BEAT. In the hope of trying to beat bladder cancer, if that's possible, and if not beat it, then certainly make a difference to the lives of those that are affected. So our mission is to increase community, GP and health professional awareness and education. That's number one. And then number two is to provide support services to the bladder cancer community. And number three is to offer help with or support cancer research, diagnosis, and treatment options. We've been around for 3 years, and we've certainly, done quite a bit for the first two pillars in terms of trying to create awareness and offering support. And our long-term goal is hopefully to look at influencing treatment options and funding and getting fundraising for research. How did BEAT start? In the picture you see Anna Lynch. She, with her 2 children, she had a very rare type of bladder cancer, which was quite invasive, and despite surgery, unfortunately succumbed to the disease. But during her end stages of life, she just thought there was not a lot around for bladder cancer in terms of support to patients, and her wish was for something like this to be started. And from so when she passed, her husband Adam Lynch decided to honour her wish and start BEAT Bladder Cancer Australia. We're a registered not-for-profit charity, and yeah, it's a patient organisation, so it's owned, managed, and run by patients for patients. And then we, as a health advisory board, we come in and we offer this educational support, checking all the information on the website is accurate, sourcing speakers, and negotiating and liaising with industry. But fundamentally, it's a patient-run led charity. So without further ado, let's get started on the outline of today's talk. We're going to, as I said, it's going to be case-based, and we're going to look at diagnosis and treatment of bladder cancer, and then we're going to tell you a little bit more in detail about the bladder cancer and what we offer to patients at the end of the talk. Now, we're also going to do some polls, so I would like to start with the first poll. So let me see if I can do this. There we go. So I'm hoping you can now see that, collecting responses. It's just asking how many of you be involved in the care of patients who have bladder cancer. 75% of you have voted. I think we need 100% response. So if all of you can vote, it's just on your little dashboard on the side. It's a yes or no. Have you been involved in the care of patients with bladder cancer? Chrysta, do we have to wait for everyone to vote, or is it possible to carry on if we wanted to?
No, you can just close the poll out and then show the results.
Okay. Okay, we're on 86% voted, and currently the responses are 74% in favour of managing patients who have had or have bladder cancer. So I'm going to close the poll now, and then share. So there's the results. You should be able to see the results. 74% of people in this webinar have treated patients with bladder cancer. All right, so now we're back to, am I back to the screen, Chrysta, of the presentation?
You're just on the app, so you just need to full screen it.
Okay, 1 second. Try again there. Is that sharing?
Yep.
Okay. Good. I'm sorry, everyone. I'm used to Zoom. We do all our support groups and training on Zoom, so this is a new platform for me. Right, let's go with the first case. So, Professor Gillatt, I hope you're around. The first patient is a 55-year-old male that presents to his GP, passing blood in his urine for the last 2 weeks. His vitals are stable, and he's otherwise well. So Professor Gillatt, I'd just like to ask you, what are some of the questions you might ask this patient in the first consultation? I hope you can figure out how to unmute. So Gillatt, are you there? I don't seem to hear him. Any suggestions? Chrysta, are you able to, there's a little microphone on the dashboard which I think needs to be green. If you just click on it, then it will become green.
Yeah, it's currently green.
Okay. So I wonder what's happening. Any suggestions, Ali? Sorry, everyone. What I may do is, while we're trying to sort that out, just respond to the question myself. So just to let you know that not all patients, in fact, many don't even have blood in the urine, otherwise known as hematuria, with bladder cancer. And this is something we're seeing more and more frequently. We're seeing younger people, so in their 40s, like Anna, when she presented, younger females, because traditionally this was a disease that affected older males, sort of 55, 60 years of age. And many women don't have hematuria, and they may just have symptoms of bladder cancer. And basically they may, so it's not bladder cancer, sorry, of a urinary tract infection, so such as voiding difficulties or burning on urinations, dysuria, frequency. So that may be their initial presentation. The GP might treat them with antibiotics, and that might not get better. So, and then sometimes they may just go back into the community and then present again and be treated a few times before that someone realizes actually there's something more going on here. Sorry everyone, I'm just trying to get Professor Gillatt on. I'm just trying to send Chrysta's number to Professor Gillatt so maybe she can help him in the background. There we go. Professor Gillatt, if you can hear me, I've texted you Chrysta's number, and maybe the two of you can converse and try and figure something out while I carry on. So yes, so some of the questions we want to ask is how, what's sort of the symptoms? Are there any associated symptoms? Usually it's painless hematuria. That's another very classic sign or symptom of bladder cancer, so that there isn't usually pain. The patients develop pain in the more advanced stages of cancer, once it becomes muscle invasive or it spreads outside the bladder wall. That there may be some features of weight loss, so just general constitutional symptoms, maybe change in appetite, and it's just sort of general constitutional symptoms, as I say. The other important thing to elicit in the history is risk factors. So we know that bladder cancer is very heavily associated with cigarette smoking. There's almost a 4 times increased risk for smokers, and people that are exposed to secondary cigarette smoking as well are also at increased risk. The other thing about risk factors are in bladder cancer specifically, there's very specific chemical exposures, such as aniline dyes, people working in the rubber industry, the leather industry, paint industry, some insecticides. So there's particular carcinogens that have been identified and linked to bladder cancer. Usually, not like a lot of other cancers in terms of family history. I mean, yes, there can be, but it's not like, say, prostate cancer, where there's a very strong correlation with whether you've had first-degree relatives that are affected. There's a high chance, you might also get prostate cancer. Bladder cancer, it's not really one of those sort of strong hereditary cancers, but yeah, it can be a risk factor. So those are the main things. The other thing to point out with bladder cancer is, and going back to our basic anatomy and histology, the whole urinary tract is lined with transitional cell epithelium, right from the collecting system of the kidneys all the way down the ureter, the bladder, and even the first part of the urethra, all has transitional cell epithelium. And that means that whole tract, all the way up from the collecting system in the kidney, right down to the urethra, is at risk of developing the same transitional cell carcinoma. So when we check the bladder, we also got to make sure the rest of the kidneys and the ureters are not affected as well, because there is a chance that they can be affected too. The next question I wanted to ask Professor Gillatt, not there, was just sort of what we'd look for in examination. So there's no specific findings for bladder cancer. Maybe they might present for the first time in urinary retention, because as we know, they bleed, and then they have clots, and then they have a full bladder, so we might feel a full bladder. They may look pale on examination. They could be anemic. They've lost a lot of blood. They may be hemodynamically unstable. They may have a low blood pressure, high heart rate. So these are some of the things, you know, if they come out of ED, or you're treating them in ED, and then they come up to the ward, just to be aware of. They may need blood transfusion. So yeah, those are some of the things to check for on examination. So what's the next step in diagnosis? We're probably going to send off blood tests. We're probably going to send off some urine. For bladder cancer, we send off not only urine to rule out infection, but we also send urine for cytology. So we know that we'll discuss the staging later. With CIS, which is carcinoma in situ, we can pick that up with doing urine cytology. Just to be aware, though, that there are other things that can make the urine cytology positive as well, not only bladder cancer. And then we may do some imaging. So a lot of urologists have ultrasound machines in their rooms, so they may just put the probe on, and they may see an obvious something in the bladder, or they may just send them straight for a CT scan with contrast if their renal function is okay. We just want to let you know that on our website, we have these printable or downloadable and printable PDF documents. And these documents you can give to your patients to take with them for their consultations. And we've done one for each stage. So if they were seen at the GP, or they've just gotten symptoms and they're going to the GP, there's one that they can take to the GP to make sure they ask all the right questions. Or if they've seen the GP and waiting to see the urologist, we have a form that they can take with to the urologist. And that asks all the questions they could possibly want to know, or may forget, or may not even realize they need to ask. And then we even have ones for the oncologist if they're going for chemo or radiation, and then all the other forms of treatment as well. So that's just something useful and practical for you, and it's free to download off our website. And in fact, we do have some handouts in your dashboard that you can take with you tonight and use in your practice. So let's move on to the next slide. Sorry, I've done a lot of talking here. And because I was waiting for our guest, the patient goes for an ultrasound. And this is what they find. And you can see here, and let's see if I can use a pointer. So this is obviously the normal outline of the bladder over there. You can see the black signifies the urine. And here, this is very obvious, and unfortunately, it doesn't always look this obvious, especially on ultrasound. You can see a large fungating papillary type mass in the bladder. So papillary transitional cell carcinoma usually presents like that. CIS is usually flat, so you wouldn't even see it on here. And very often, as I said, especially if the cancer is caught in early stages, they're going to be so small. Very often the folds of the bladder may look like the cancer, and you may not even see it, which is why the gold standard diagnostic investigation is a cystoscopy. No imaging, no anything else except for cystoscopy. Looking inside the bladder is the only way to make the final diagnosis, the diagnosis of bladder cancer.
Right now.
See it with your eye. Hello? Oh, hello, Professor Gillatt. Are you there? I heard something. Hello. That's all right. You're with us now. I've done quite a bit of talking, and maybe you can jump in here. This is, I've just told them the ultrasound findings here of this bladder cancer. Maybe you can tell us what will be the next step. What will you do next?
This is obviously the patient with hematuria. I'm sure I've said this already, but blood in the urine and bladder, there's going to be a high suspicion for bladder cancer. And presumably we talked about smoking and other risk factors. But bladder cancer occurs in people of all ages. So the next step you do some form of imaging. That also sounds quite reasonable, and I guess the CT is more preferable, CT urogram. But if they're doing a mass in the bladder now, sometimes the ultrasound can get it wrong. Like it could be a bit of prostate sticking in the bladder, or it could be a stone recently that looked like a bladder tumour, but this looks to me like a mass that's in the bladder wall, and therefore extremely likely with the history to be a bladder cancer. So you need to think that's in line with the history, and we need to actually confirm it's a bladder cancer. So the next step would be an endoscopic examination. I usually like a CT urogram to just check the upper tracts. But in general terms, you need to do a cystoscopy on this patient to resect the tumour to get confirm the diagnosis, to get pathological assessment of stage if it's invading the bladder wall, and to get some idea of the grade of the cancer. So this next step is a procedure that's often done poorly or in the past it was, but it really is a very important process to make sure you understand what type of cancer it is and how aggressive it is, and if it's invading the bladder wall, and indeed whether there are other cancers in the bladder, because as you know, bladder cancer are often multifocal. It can be in several areas of the bladder. This looks like a single tumour, and therefore resecting it and sending it off for pathological evaluation. You can question whether you should do separate biopsies for the deeper layers of the bladder to see if there's muscle invasion, or separate biopsies around the bladder. That may well be a reasonable thing to do, but you try to assess the risk that cancer presents to the patient by doing the resection.
Perfect. So on the screen, I've put up the procedure, which is the transurethral resection of the bladder tumor. So that's going to probably give you it's going to be diagnostic, but it's also going to be therapeutic, isn't it? So it's going to take out whatever we can see with our eyes, and will give us something for the histologists to review. It's done in theatre under general anesthetic. Sometimes it can be done under spinal anesthetic. And then the patient will have a 3-way catheter put in, which you see on the right of your screen over there. So it has 3 ports on the end compared to your normal catheter, which has 2 ports. And that just allows us to connect up an irrigation tubing for fluid to run in, and that mechanical running, continuous running of fluid, that has a mechanical effect, which helps with hemostasis and helps to just stop any bleeding and clear out any clots. So the patient usually will stay over in the hospital, maybe 1 day, maybe 2, depending on what the irrigation does. So that's why I want to show you on the next slide. So the patient's now going to be in your ward under your care, and this is day 1 post-surgery. So I want to do a poll to see if everyone thinks that what everyone thinks about the color in the bag. Do you think that color is acceptable or not? And the poll is now open for day 1 post to your RBT. Is that an acceptable color of urine? On the left, while you're doing that, you can see the irrigation bag needs to be placed sort of quite high up to allow the fluid to run down. And then the bag should be on the floor. There should be no kinks. And it should be running freely. Whatever's going in must come out. But we'll talk more about that in a minute. So 81% of people have voted. I'll just give you another few minutes to say, to give your responses. Do we think this is a normal color urine day 1 post-surgery? Is it acceptable? All right, I'll close it and I'll share the results. 100% of people, all right, have said yes. And yes, that is an acceptable color day 1. All right, so back to the presentation, and let's just make sure, Chrysta, I hope my slides are sharing again. So the irrigation runs again overnight, but it's now 3 in the morning, and can you see the slide, Chrysta? Sorry.
No,
is it there?
that's dropped out of the presentation.
Give me a second. Yes, And now, you can see it. Yeah. 3 a.m., 3 o'clock, a patient had to be resuscitated. Everyone in the night, all the night staff had gone to deal with the resuscitation and then didn't have a chance to change the irrigation of our patient. And now the patient is writhing in pain. You look at them, that's what you see on the abdomen, this very distended abdomen, and then you look at the bag and you see that. So we're going to jump to another poll now and see what everyone will do now in finding the patient. So the question is, what will you do next? And there are your options. Call the medical team, change the catheter, flush the catheter, change the urine bag, or restart the irrigation. Give you a few seconds. So, yep, 3 o'clock in the morning, the patient's very uncomfortable. The bladder looks, or the abdomen looks distended, and nothing is drained in the bag. Give you another 15 seconds to respond. Okay, closing the poll and sharing the results. So 52% of everyone said they'd flush the catheter, 28% said they'd call the medical team, 8% said they would change the bag, and 12% said they would restart the irrigation. So now I'm going to ask for some help from Ali Morrice, the Urology nurse. Ali, I hope you're still with us there. Can you tell us what do you think has happened here?
Yes,
what would you do?
I would flush the catheter. Yeah, I'd go to 52%. Probably just the fact that, you know, likely this guy's going to be in clot retention just because he's had no irrigations going. And of course, it's going to happen at 3 a.m. in the morning. This is when it does happen, and you're very busy and not a lot of staff. So, yeah, I think you would start with that and see if you can, you know, dislodge any clots that are in the bladder, for sure. And then I guess, yeah, see if you can get it to drain, definitely, and then restart you. Once you can see that the patient's in a lot of pain, obviously, but as soon as you can unblock that catheter, by restarting the irrigations, you're just, you know, risking just filling his bladder more. So there's obviously something blocking the end of that catheter.
Correct.
So that would be my yeah. I
agree. So yeah, there's probably a big clot sitting at the end. So you want to flush, aspirate that clot out if you can first, and then see what. And then if it's just one clot, it will start flowing again. You'll just get a gush of urine, and the patient will be instantly relieved, which is one of the most rewarding things in medicine, isn't it?
Yeah.
That instant relief from a patient in retention, and the urine should flow. But sometimes it's probably not the only clot, so you're probably going to have to get your basins. I would get someone. What I normally do is get someone else to join me. Have 2 basins. Get two catheter tip syringes, big catheter tip syringes, and you just work together. Fill up the one, and then you aspirate, you flush, and while you're doing that, your colleague is filling up the next one, and you just go 1, 1, 1, 1, 1, and you work very quickly to unblock, aspirate everything. Sometimes you've got to pull a bit and create a bit of negative suction on the end of the catheter tip syringe, which just sort of helps to pull, and like a vacuum effect, pull out any clots. Sometimes that works. Sometimes you've got to give a forceful push the other way in to sort of dislodge a clot at the end of the catheter. Obviously, you've got to be guided by the patient's pain. That can be a bit uncomfortable. And if it's an old patient with a thin bladder, you obviously don't want to rupture the bladder either. So everything done carefully. Make sure that whatever goes in, like I said, must come out. That's very important. You don't want to just keep pushing more water in there. And then once you've tried this, I would certainly call the medical team. Unless you're very experienced, it might be risky to change a catheter. Changing the bag sometimes can help. I mean, there's no harm in doing it. Sometimes you can just disconnect it and just let it and hold it up, and if there's a clot in there, it might run down in the bag, and that it might be a simple fix. But you probably, the catheter is going to need to be flushed. All right, great. So let's move on. And the histology results has come back, Professor Gillatt, and it's showing a high-grade T1. And we know that bladder cancer can be either non-muscle invasive or muscle invasive. Do you want to talk us through just sort of briefly the staging of bladder cancer?
Well, this is probably one of the most important decision points, isn't it? You can try and decide on the patient's subsequent course, the risk for cancer is to them for their future, and the sort of therapeutic management path you may well choose. So this bit of information is probably central at the beginning of the patient's journey to where they go from there. And this really demonstrates the invasion. Superficial TA means there's a lesion that's just lying on the surface of the bladder. They often look very warty, almost like warts or papillomas, and often are very low-grade cancers which carry a pretty good prognosis. They may, once you've cut them away, occasionally recur, but rarely progress or metastasize. Laminar propria invasions important because it still appears to be a superficial or cancer lying in the bladder wall, but it's showing some signs of starting to engage tendrils into the first layers of the bladder. As you go around, when it starts to invade into the muscle, these tend to be more aggressive cancers anyway. It's then got the propensity to spread elsewhere. So you go to the muscle invasive end, they're the patients that will need some, if they're fit, and not obviously many bladder cancer patients are older and they're smokers, they've got other comorbidity, heart disease, they're all fit for aggressive treatment. But if you're getting muscle invasive cancers, they tend to be more aggressive and they tend to need to be considered for more radical treatments, which may involve cystectomy or radiation or chemotherapy or some combination of those treatments. If they're still not in the muscle, you can hopefully treat them with local therapies by resection, and if they're low grade, supervision, regular cystoscopic checks. If they show features pathologically of being higher grade and more aggressive, and they've got early signs of invasion, they are a risky cancer. They're not immediately threatening, but if they're left unchecked, so a fair percentage can progress. So that's one important subgroup that this gentleman, I think, falls into of a high-grade cancer. It's aggressive under the microscope. It's not deeply invasive, but it shows that shows some signs of getting into the first layers of the bladder. And these cancers are potentially quite dangerous if they're left unchecked. And features that make them even more threatening are if they're multiple, or if they recur quickly, you cut them away and they're back again fairly quickly, or if they've got associated carcinoma in situ, CIS, so otherwise they've got multiple cellular changes in the bladder wall. There's a group of patients who've got high grade and almost like a rash around the bladder. The bladder sort of turning malignant, but it's not deeply invasive. So this gentleman has got high grade T1 disease, and it's a single tumour. It's quite large though, so he's got some features that would suggest he's at a reasonably high grade risk of this recurring and progressing and threatening life with time if unchecked. So therefore, it may need more treatment than just a resection. Is that a reasonable roundup?
Yeah, thank you. Yep. So thanks for that. So sorry.
This is a decision point. It's not just dividing patients into non-muscle invasive and muscle invasive, but you've got to take into account the grade, the aggression of the cancer as well. In some ways, also the behaviour of it, which obviously you can only get by watching how it behaves. So that's not something that's available at the first visit. Okay.
Thank you. Yes. Just a reminder, everyone, if there are any burning questions, you are welcome to post them in the chat function. Chrysta's monitoring that, so do feel free to pop something in there and we can try and respond to them either now or at the end of the session. But yeah, please don't be silent. We encourage active engagement. So this patient with a high-grade T1 has been given the option of local therapy and has decided to opt for the BCG treatment. So what is BCG? BCG is basically the same as the TB that you vaccinate with. It's an inactive form of TB. Why are we giving people with cancer TB, you may ask? Because what it does is it stimulates the immune system to create a response in the bladder, which has an effect on the bladder cancer. So that's how it works. So it's a kind of immunotherapy. So you've all heard of the new chemotherapy, immunotherapy, if you will. The latest treatments for lung cancer, melanoma, and even bladder cancer, they all work on the immune system. But we've been using the body's own immune system to fight bladder cancer for many, many years. And it helps to prevent tumor recurrence, and it helps to prevent tumor progression. So we resect, and then we wait a while, usually about minimum 2 weeks, for everything to settle and heal, and the bleeding to stop. And then we bring the patients back for BCG. Now, I want to do a poll here. This patient has arrived for their BCG treatment. However, you do a urine dipsticks, which is the first thing the urology nurse is going to do, and these are the results. So I have another poll for you, and the question is, are you going to proceed? Are you going to give BCG to this patient today? And let's go. Sister, yes or no, 50-50. Will you be giving this patient BCG? I'll give you another 15 seconds. And I will close and share the results with you all. So 77% have said no, 23% have said yes. So I will ask Ali, what is the correct answer? What has happened here? And should we be giving BCG?
No, agree. We would delay treatment at this stage and treat the infection. So yeah, obviously send it off to be cultured to obtain the sensitivities. And then you can't give BCG. As you said, it increases the immune response in the bladder. So you've already got a angry bladder from an infection, so you're risking transferring the medication sort of systemically through the wall of the bladder, which can make the patient very unwell. So yeah, you would delay, treat, retest, and then bring them back, delay them for that week.
Yep, I agree, because one of the side effects of having the BCG as well is also getting cystitis afterwards as well, isn't it? A lot of our patients that get BCG end up getting an infection. But yes, you're 100% right why we wouldn't give it. So send them home, make sure you've alerted the doctor to give them a prescription of antibiotics, and and then repeat the urine MCS and make sure that the infection is cleared. And then bring the patient back for their BCG treatment. So Ali, do you want to tell us now the infection's gone, how do you administer BCG to these patients?
So as you can see in that picture there that we've got up on the slide, so it's a closed system that we give the BCG. It's given once a week for 6 weeks. That's your induction dose. So we always do a dipstick, obviously, pre every treatment, and then so an IDC is inserted. The BCG is inserted, as you can see, through the catheter and a syringe, which is all pre-made up, and you're using your PPE and also abiding through your ADAC chemotherapy precautions. You've popped it in the bladder. We keep it in up to 2 hours, and then as long as the patient can tolerate that. Some patients won't get to the 2 hours, just especially as the treatment goes on. but you sort of get it to as much as you can. You try and get them to either lie side to side on their back. Sometimes patients can go prone, just to cover the whole wall of the bladder. Yeah, so prior to that, they decrease their fluid intake as well for about 6 hours before they have the treatment, just to keep them a little bit dry and keeps from diluting the treatment in their bladder. And then once they've got to their 2-hour mark, then it's drained, released, and into a still or closed system, popped away into a chemotherapy, your purple bins. And then we just encourage them to drink afterwards. And then, yeah, once they pee, normally they can go home. So based on all that, we use the EviQ evidence and their protocols. I guess different institutions as well, they'll do it differently. I know some places do it in a oncology unit. Where I am, we do it in the day procedure unit. So, yeah, obviously you have to be competent, BCG competent, and all the chemotherapy competencies. But, yeah. So, and then, yeah, once they're good, yeah, and then they're okay and they're peed, and send them home. And then they come back for the next treatment the next week.
Are there any immediate complications you're worried about?
Well, allergic reaction, a reaction to it, I suppose. So you'd be doing a full assessment on these patients as they come in, and just bypassing catheters. In my experience, sometimes if we give them a little bit of like a anticholinergic or something, if we know that they're going to have an overactive bladder from the treatment and that it's really angry, that can help calm it down, of course with medical advice. But if you've had a traumatic catheterization at the time of putting the catheter in, you don't proceed to treatment. Again, you know, you've caused trauma there. That's probably most of the things I can sort of think of in terms of reactions, but yeah, at the time.
Yep, thank you. So a few days later, the patient calls your office, Ali, and says they have low abdominal pain, they're going to the toilet frequently, there's urgency, there's dysuria. I'm going to ask the audience again first before we discuss it. I'm going to ask them what they think. What would you do next if you're in the outpatient setting and this is how the patient presents after you've given BCG? I need to launch the poll, and there we go. Would you send the patient to the emergency department? Would you send them to the GP? Would you encourage them to just drink more fluids? Send them to get their urine tested, or just tell them to drink some cranberry juice? Give you a few seconds to respond. All right, another 10 seconds. All right, closing the polls. All right, there's the results. So most people said send them to get their urine tested. 21% of people said send them to the emergency department. And then the rest have said send them to the GP, and a few people have said drink more fluids. So Professor, what are some of the common side effects of BCG treatment and how they managed?
Well, the common ones obviously are, obviously you get a urine infection like any instrumentation. Inflammatory symptoms due to the fact that it is causing inflammation. That's how it works. I guess you have to be slightly careful of there are occasional, I've ever seen it once, serious reactions, grade 4 reactions where the patient gets a severe reaction of the BCG, whether it's allergic or otherwise, and collapses. But not going to happen with the first dose, but it's quite rare as well. You do occasionally get tuberculosis-like illnesses. I've seen it a small number of times. You get tuberculosis in the scrotum twice, I think I've seen, and some European centres used to give people tuberculosis therapy with a BCG. That's the minority of centres. So they feel like the symptoms are continuing afterwards, despite treating infection and things. Just be aware they can occasionally get a TB-like illness and may need referral to a centre. Again, that's sort of 3 or 4 cases over several hundred over the years. So the common response is going to be inflammatory symptoms, it's just irritation.
Yes, and the anticholinergics, like Ali said, do work quite well to help with some of those irritable symptoms.
And of course, the other thing to mention is that most of the evidence suggests that if you respond to BCG, first of all, you don't respond to BCG with a high-grade cancer. That's a bad sign. That's a bad prognostic sign. So these patients need follow-up with cystoscopy, obviously. But if you do respond, the best way of keeping the disease controlled and not occurring is to give maintenance BCG, so probably repeating at least, after 3 months, another 3 doses, perhaps even up to, some studies up to 3 years afterwards, and certainly for the first year after diagnosis, maybe more evidence that control the disease for longer by giving maintenance therapy, assuming they're not having a lot of side effects from the initial therapy.
Yep, thank you. So as you can all see, bladder cancer patients are frequent flyers. You will get to know them very well in the hospital. They come back from cystoscopy after cystoscopy for many, many years. And that's why bladder cancer is a very expensive disease to treat, because of all this follow-up that goes on. And it is a very complex disease. BCG and getting topical treatment can make a lot of our patients anxious. So I do run a support group, and we'll talk about that just now. But so I hear the patients and their experiences, and they get very anxious, waiting for those results and going in for the test. And then at the back of their mind, there's always that, as Professor said, the possibility that the BCG has failed and they may need that cystectomy. So they're always living in limbo, waiting. Am I going to need a cystectomy next? All right, so let's move on to another case. And this is the other scenario. So this is a patient, 40-year-old female that is diagnosed with a muscle invasive, so the T2 bladder cancer. There's no signs of metastatic disease anywhere in the body. So as Professor said, all the scans have been done, the bone scans, the CT scans, the chest has been checked. There's no evidence that bladder cancer has spread to any of these sites. And to any of the lymph nodes either on CT scan. So the patient decides that they're going to have a robotic radical cystectomy. So Professor Gillatt, again, I'm going to ask you, and obviously if we're taking out the bladder, that means we need to replace it with something or create another way for the patient to get rid of their urine. So I'm going to ask Professor Gillatt, what are some of the considerations now for surgery? Because there's obviously traditional open surgery, but then there's also laparoscopic. We now offer robotic in a lot of centers. A lot of public hospitals are doing robotic cystectomies as well. Can you talk us through some of the considerations and how you choose which surgery to do for this patient?
Well, the first thing is that the primacy here should be treating the cancer, of course. The treatment for the cancer is removing the bladder, and in a woman, traditionally that would mean taking the bladder out, the uterus, perhaps the ovaries if they're postmenopausal, and a slither of the front wall of the vagina. Now, you can preserve the uterus and the vagina in younger women if the cancer is not posterior, not going in that direction. Certainly, vaginal and sexual preserving cystectomy in a younger woman is important. So, while the primary aim should be to get rid of the cancer, you've got to look at function afterwards. So the bladder should be removed, probably the uterus, but trying to preserve the vagina where possible. Whether you take the ovaries out or not depends partly on their menopausal status and whether they need them or not. You should also do a lymph node dissection, of course, which adds to both time and some morbidity. You get lymph leakage afterwards and lymphocytes forming. So how you then do the operation is partly depends on experience and availability of equipment. Whether you do it robotically or open or laparoscopically, in the end, it should be the same operation. The advantage of a minimally invasive approach may be quicker recovery. Needs more experience, probably, in training as a surgeon and a surgical team in theatres. There are some studies that suggest there's no difference in outcome between robotic and open surgery over a 3 to 6 month period. Others suggest there might certainly be difference in terms of more rapid recovery with a robotic approach. So I think whether you do robotic or open depends on experience and your review and your team and the available equipment, personally. You shouldn't be speaking from a very UK perspective, but I believe you should be doing a vasectomy every 2 years. You should be in a centre that's doing a number. In the UK, we were doing 120 in our centre every year for it. You have to be doing a minimum number in each centre. I think Australia's moving that way. Certainly, the New South Wales Cancer Institute is discussing minimum numbers. They're quite low at the moment. Minimum numbers are 8 in a centre. But there are 200 vasectomies a year done in New South Wales and 44 different hospitals doing them. It's not that you as a surgeon or you as a nurse are any better or worse than anybody else. It's just the whole team effect. If you're doing operations regularly, the whole team gets better at doing them. And you learn how to deal with the complications. It becomes a more routine event rather than a vasectomy done every year in some small hospital. It becomes a big event and doesn't always go well sometimes. With regard to what you do about the urine when you take the bladder out, again, there are options. An ideal conduit is the standard option, as in most Western countries for many years, although some countries even still do occasionally still use rectal diversions, which have their issues but are a fallback position. The other alternative is some form of constant diversion, either reconstruct the bladder, which is very effective in women, in fact, probably more so than in men in some ways, or a constant cutaneous diversion, which has got its issues. So I think, in general terms, it's between an ideal conduit, which would be the preferred option for most people, or a bladder reconstruction, assuming the cancer is away from the urethra and allows you to put a new bladder onto the urethra without risking cancer clearance. Does that answer your questions?
Yes, thank you. So as Professor said, we use bowel, we use ileum usually to recreate a new bladder and connect that as a stoma to the bladder wall, and the urine just drains out into a bag. Or we make a new bladder and connect it to the existing external urethral sphincter that's there, and the patient actually has control and is able to retrain this new bladder to know when it needs to urinate, and then actually able to void in a normal way. Some patients may need to catheterize because they don't get that quite. They're not able to retrain it as it was before because it's bowel. But we have patients in our group that are able to void as normal with a new bladder made out of bowel. Just to say that we are going to run a bit over time, so get your partners to get started with dinner. We want you to stay with us. If you do have to dash off, remember there's going to be a second webinar coming up on the 22nd of July, so please join us for that as well. And we'll be talking to our actual patients about their experiences. But we're not done, and we want you to please stay with us. We won't be that much longer. So as Professor mentioned, it's a big surgery. It sometimes takes the whole day. There's a lot of psychology here about having your bladder removed and your reproductive organs, many patients become incontinent, infertile. There's a lot of issues at play, and this is when they turn to our support group for help and just reassurance, and that's where we in our support group have other patients that have been through this and are able to share their experiences and share how their lives have gone back to normal. We have patients that ride motorbikes that are back to riding motorbikes, patients doing yoga that are back to doing their yoga. So it's just to show that you can live a normal life and you can beat and survive bladder cancer. So please refer your patients to our support group. I'll tell you more in a second. Now, Ali, there is a lot of psychological stuff, especially in women, and regards to maybe having their sexual and reproductive function altered. Is there any advice you want to give there?
Kalli, it's hard. It's really hard. I mean, firstly, they're dealing with, a life-threatening cancer, which they have to get their heads around that to start with. The next thing is they're having whole organs removed, like you said. It's a complete change of life for them. Their quality, because we do, you know, we see the outcomes. These patients are terrified, to be honest. So they also have financial burden as well, which is big, because, you know, if they're young, like this 40-year-old lady, she wants to go back to work, she may have children, married partner, all that sort of thing. So if the first thing, you know, we would try and get that off the ground would be a psychology, a referral to psychology, but we have to do that with their consent. We can't do that without them saying. But, you know, we try and encourage that, just to talk about that diagnosis, their fears, and, you know, what's ahead. You've got obviously the body image issues in terms of stomas, and that becomes, you know, obviously again reflects back onto sexual function. You know, will my partner like me anymore? Will they be attracted to me? That sort of thing. And then just, I mean, I know just in a separate thing is we have, and I'm assuming, you know, a lot of places, regional patients that we bring to major centres for these big surgeries. So they're basically, you know, they're away from home in a foreign environment, from people they don't know, away from their families. So there's so much to consider for these patients that, you know, it's hard. It is hard for them, and that's it. It's good that we've got. It's amazing that BEAT are able to provide that support. You know, a lot of that support, patient stories, patient support for them. So there'd be a lot of allied health referrals, which is a lot of what I do, is allied health in terms of social work, psychology, dietitians. You know, there's a whole team that are involved in that. Yeah, so
you hit the nail on the head. It's a multidisciplinary
Yeah.
approach, for sure. This is one of those cancers where, well, I mean, all cancers should be a multidisciplinary team, but more so with bladder cancer. There's just so much involved. So let's go on. So the patient comes to the ward to see you, Ali, and of course that's her body habitus. And what are some of the practical tips you can give to our nurses with preparing this patient for theatre?
Oh, on the day of theatre, or just leading up to, Kelly? Sorry.
Yeah, just the day before and on the day. Yep.
So generally, and I guess it's surgeon preference and surgeon sort of dependent, in terms of, you know, bowel prep or diet, pre-operative diet. And I think we're speaking about ERAS shortly, but a lot of them do the high-calorie drinks and things, you know, the day before and even the morning of, and that sort of thing. Otherwise, obviously fasting. They've obviously always had an anaesthetic review, that sort of thing. But
yes,
normally stoma therapists would cite, a stoma site for these ladies or men. Yeah.
Okay.
So you kind of be looking at. Sorry.
Go ahead, Ali. What are some of the things?
Stomas, you're looking at pant line. So obviously I don't mark them, the stoma therapist does, but you'd be looking at pant line, creases, bumps, lumps. It's normally on the right-hand side, and that's due to, and you can clarify this too, Professor or Kalli, is that the fact that how the ureters will join up to the stomas. So it's generally on the right-hand side, just due to that anatomy and how the ureters line up. But yeah, you're looking at the patient and they're sitting, they're standing, they're lying, just so you can sort of help cite, because when their patients are laying on a table, for you guys, for the surgeons, it's obviously so much different. Yeah, so that just helps give the surgeon a guide to where they're going to place that and best for the patient to reach. And as long as their eyesight and hands are okay, generally they can manage the stoma okay.
Yep, those are all very important points. Thank you, Ali. So the patient goes for surgery, and it's now, usually they go to ICU because it's, as I said, such a major surgery. Patient was discharged from ICU day 2, very lucky. Let's say they had robotic surgery, and now you're in the ward, and the stoma bag is leaking. So you need to change the bag, and when you change the bag, you see this in the picture. Is that a normal looking stoma to you, Ali? And what are these blue things sticking out?
Yep, that's a beautiful stoma. Whoever
Sure
created
is.
that.
It wasn't me. I can't like to take credit, but I can make it like that. I'm sure the professor does too. But yes, can't take credit for this one.
I wish they all.
Yes, yes.
So the blue tubes that are hanging out there are stents, and the ureteric stents that are going from the kidney down to the ureters to the jaw and out through the stoma. So basically to keep the anastomosis, so the join to the stoma, from twisting or narrowing while it's healing, and it just allows the urine to drain as well.
Yep. So it is normal. Don't get a fright, everyone. Sometimes just don't pull them out. Sometimes they're stitched. Well, usually they're stitched in, but sometimes they can fall out. So just make sure you don't pull on it, or the patient doesn't pull on it. And usually about 2 to 3 weeks, either they fall out on their own, or some surgeons like to take them out themselves. Professor, are you able to tell us what other drains can the patient expect after this kind of surgery? There's usually a lot going on. They're covered from head to toe in drains and wires.
I mean, people do different things. I mean, most people put a drain in to drain the conduit or the pelvis. Probably some people put 2 in. Some people even put a urethral catheter in the pelvis as a drain, which confuses people sometimes if no urine's coming out of it. There is some evidence from enhanced recovery programs that keeping the drains to a minimum, or even trying to avoid them, is a help to recovery. I tend to still use 1 drain, but traditionally often people used to use 2 drains and plus or minus a catheter through the urethra as a drain. So you have to explain to the patients and the team looking after them what each of the drains is for. Of course, if you have a near bladder and not a ideal conduit, you may have catheters and coming from the stents coming out of the abdominal wall and catheters draining urine. You have to actually explain which tube urine's coming out of and which tube urine shouldn't be coming out of. So I think it's important to tell everybody what each tube is for, including the patient.
Yep, communication is key, and sometimes maybe it's easier just to label each thing, put a little label around it so everyone knows what's going on. Because very often the surgeon is going to ask you for drain outputs. Sometimes there may be a little leak and that needs to be monitored. So, everything should be clearly labeled and all outputs should be monitored, which I'm sure most of you know already. Anyway, so now it's day 3 post-cystectomy. You notice for the last 6 hours, the patient hasn't had any urine draining in the bag. And when you look at the bag, you see this. So it's time for another quick poll. And the poll is asking you, how would you manage this stoma? Go for it. Would you call the medical team? Would you flush the stoma with saline? Would you insert a Foley's catheter into the stoma? Or would you reassure the patient that this is normal and there's nothing to worry about? All right, give you another 5 seconds. All right, closing the poll, sharing the results. So most people actually said call the medical team. Some people said flush the stoma with saline. Others said put a Foley's catheter in. and some said reassure the patient that this is nothing and it's normal, which I'm not sure about the last option, because you do want some output from the patient. Ali, can you tell us what's happening here?
I'm just looking at that. I would call medical team. Just that you've still got the stents in, unless they're fallen out. It's a bit hard to see on the picture. But yeah, definitely if they haven't passed any urine for 6 hours, which you should, that's a really long time. So I'd be really worried, I think.
Yes.
But I'm not.
I mean,
yeah,
yes, you can also flush it. I mean, it's probably just mucus. So remember, because you now got bowel instead of bladder, the bowel does continue to secrete mucus. So you do get little mucus plugs that come out into the conduit. So there's no harm in just giving it a gentle flush. Sometimes we even ask, if we see there's a lot of mucus coming out, we may ask the ICU or the ward nurse just to give regular flushes, just to help flush out that mucus so it doesn't keep getting blocked. And sometimes if it's really causing a problem, we may have to put a Foley's catheter in. And just to note, the same thing would apply if the patient had a catheter in with a near bladder. They can also accumulate mucus, and that may need to be flushed. So then it's day 4 post-cystectomy, and this is unfortunately quite common after cystectomies, where you see a patient that has not opened their bowels and is now started vomiting. So what do you think? We'll do another poll. Has happened now for those of you that have managed post-cystectomy patients? You would know what's happened here. Poll open. Did the patient have a bad takeaway meal from a relative that decided to bring them some food? Did they have a reaction to medication? Did they have an allergic reaction to something? Do they have an ileus? Or is there a possible bowel obstruction? I'll give you another 10 seconds. We are nearing the end of our presentation, so please hang in there. We won't be much longer. If you do have to rush off, once again, please join us again on the 22nd of July for part 2 of this webinar series. We are BEAT Bladder Cancer Australia. I'm going to share the results of the poll with you now, and it is 61% of you have correctly said ileus. We can't rule out a bowel obstruction as well, though. That's certainly higher from the differentials, but a lot of our patients get ileus because of the shifts in electrolytes, and now you've got urine being absorbed through bowel. There's a high risk of ileus. Also, they're taking a lot of opioids for pain because it's quite a painful procedure, so there's a risk there as well. And then, of course, they take time to start drinking and eating. Professor, will you tell us how do we now manage this ileus, and what are some ways to prevent the ileus?
Two different questions. I mean, I think you reduce the risk of ileus with social technique, reducing opioid usage, early mobilisation. I mean, some people believe early feeding, certainly starting. I mean, at a phase of giving patients to chew gum. There's been one trial that suggested it helped get bowels moving quicker, and another one that suggested it didn't. So, as with many things in medicine, contradictory results. But certainly, getting the gastrics working may help things move. I mean, the problem with an ileus is the fact it's all a functional obstruction, and it can be difficult to work out early on whether it will resolve or whether there's underlying mechanical obstruction that you've not picked up. And the only way to find out often is to observe. If the patient vomiting and distended, you're probably going to need to deflate them with an NG tube, unfortunately. IV fluid correction, X-rays, because obviously you can see where the gas is getting to. Is it you've got gas getting through the colon and other material, it's more likely not to be a mechanical obstruction. I think you'd be quite happy to treat this with old-fashioned drip and sucking, fluid replacement, electrolyte correction, and imaging. Obviously, with ileus, it should resolve. Usually, the average time of getting bowels open is about 4 or 5 days, isn't it? So, if it persists, you may want to do some imaging with a gastrographic swallow, for example. there's some evidence that gastrography by itself might get an ileus moving, but it certainly would tell you whether there's a mechanical obstruction or whether there's actually contrast getting through the small bowel into the colon, which would suggest it's not a mechanical obstruction. So I think you've got to manage the fluid balance, the symptoms of vomiting and distension of the tube, and imaging to define what the problem is.
Great. Now, we've mentioned ERAS before, ERAS, and you're quite an advocate of this, and you've been involved in a lot of the research out of all the many thousands of cystectomies you've done. What is ERAS?
Well, ERAS is a concept, isn't it? Enhancing recovery, and it's a complex and multi-part process, and it changes. It was brought in originally by a Danish guy who did colon resections and got the stay down from about 14 days to 2 days, he claimed, by using an enhanced recovery. It's avoiding unnecessary bowel prep, earlier feeding, pre-habilitation with appropriate calories, for example, and hydration. It's trying to reduce the opioids or take it away entirely if you can, post-operative by using local blocks or ketamine infusions or anything that may aid recovery by avoiding opioid blasts for the patients. It's a whole process. I mean, it's something probably needs to develop locally. We started out in the UK before I came here in 2005, based on colorectal surgeons locally who started to do it. It hopefully gets people up and about quicker, recovering quicker, but also hopefully stops that. I mean, if you look at really at cystectomies in the old days, I'm very old now, it really took patients a year or more to recover properly from a cystectomy. And that's partly because some of them said it to me, I didn't really turn the corner until a year or 14 months after the operation entirely. I think the idea of enhanced recovery is to try and stop that large catabolic problem they get afterwards that takes a long time to recover from.
Thank you.
It probably needs to be developed locally for your own needs. I mean, there's really simple things done, like putting on the wards where the cupboards full of build-up drinks were placed at one end of the ward with arrows pointed towards them, and patients, once they were out of bed on the second day, were allowed to go and walk down the corridor with help to go and fetch their own snacks and appropriate drinks. I mean, different things need to be developed for your own needs, but it's the general principle of getting patients sorted out properly before the operation, making sure they're well worked up, making sure that surgery is as minimally invasive and as less traumatic as you can, and then making sure that you work on their recovery afterwards, avoiding NG tubes, avoiding bowel prep, avoiding opioids where possible. And it's not going to be a one-size-fits-all, it's going to be something you develop for your local practice.
Yeah, it's a protocol that develops, and it's got to be shared across teams. Nurses and surgeons involved, ICU team need to be involved as well. So ERAS is... Sorry, go on.
We've got 5 of our senior nurses to go on a course, and they set it up basically, and we just did as we were told.
So enhanced recovery after surgery, ERAS is the term. Something else I also have found
it's not just after surgery, it's enhanced recovery based on the whole process from pre-assessment right through to recovery to discharge. It's a whole process, not just the bit after surgery. So it's recovery is not the point you decide to do the operation, not from the operation itself.
Yep. Fair enough. Something else I've found useful to prevent ileus is Maxilon, metoclopramide. It has a prokinetic effect, and it just helps to push and encourage the bowel to move forward in combination with the chewing gum. And yeah, I always tell the patients, the sooner you get out of bed, the sooner you go home, and that usually gets them out and moving. And okay, so thank you, Professor David Gillatt. And as I said, head of surgery at Macquarie University Private Hospital. Before that, hails from Bristol in the UK, had one of the largest case series of open cystectomies in the UK. So we're very fortunate this evening to have had him sharing his expertise with us. I have another poll based on everything that we've discussed here today. Who wants to become a urology nurse? If you're not one already, poll is now open. Yes, no. Have we convinced you to become a urology nurse? Few more seconds. We're almost at the end of the talk. I would like to tell you more about what we do as BEAT Bladder Cancer Australia and how you can get involved. And again, if you have to leave us, please remember part 2 coming up on the 22nd of July. All right, and closing the poll now, sharing the results. 62% of people have said yes, they would like to become uro-oncology nurses after our presentation today, which is great news. We haven't bribed anyone in any way. This is purely organic, which is great. Now, I want to ask Ali, can you tell us, why did you choose to become a urology nurse?
Loving that slide. To be honest, I actually fell into urology. I started my nursing career, I'll let my age out, but 25 years ago. And then it just progressed, and I sort of went into surgical nursing, and then an opportunity arose in a urology outreach situation. So, which in a service at the institution at the MATA I am at the moment, so which was quite unique in its day, but obviously everyone's doing outreach type services now. So that's where it came, and then the oncology part came. I just loved helping the patients basically, and bladder cancer was a bit of a passion now. So just trying to help patients because it's a tough one. It's a tough one for them. So that's basically how I sort of fell into it, basically. Yeah.
Do you have any advice for younger nurses that may be pursuing? I mean, we've seen now over 60% that are keen to become urology oncology nurses. What would you tell them?
Yeah. So I would encourage you guys, anyone, to make sure you join your local urology nurses society. So they're on pretty much every state, which is ANZUNS, USANS. I mean, it's a bit sad we haven't had any conferences for such a long time, but it's such a good, those societies are, those societies are fabulous. There's wealth and wealth of knowledge in the urology world in those societies. So if you're not already, get onto that. A lot of education opportunities. Just ask questions, get involved. It's a really good area.
That's great, Ali. Thank you again also for your time and your expertise this evening. 25 years, we're very fortunate to have you join us and give us your input and advice. On a final note, sorry, go on.
No, just thank you very much. It's, it's been a pleasure. Yeah.
Thank you, Ali. So that's the nurse's journey, the patient journey. So if you visit our website, it's www.beatbladdercanceraustralia.org.au. That's our landing page, our home page, and our driving home message is blood in your pee, see your GP. And that's why we've got the red grapefruit there to signify the blood in the urine. But like we said today, doesn't always present in that way. And we actually, the overarching message is any change in your urination, any new symptoms that weren't there before, get yourself checked out, get your GP so that they can pick this up, and early detection saves lives. Our website is structured in a way that there's a journey from symptoms to diagnosis to treatment, and then the aftercare, the support. We've got a lot on health and well-being, exercise, nutrition, to palliative care, to alternative medicine, a very new concept, integrative medicine, and then life after treatment. So there are ways for you to get involved. You can join our advisory team. You can help with fundraising. You can become an advocate. You can start your own support group, and we've got all the resources to help you do that under our umbrella as BEAT. You can help to start your own Anna's walk. So every year in May, in memory of Anna, we do a walk along the northern between North Narrabeen and Monavale. We walk along there to raise money for bladder cancer in memory of Anna Lynch, and all the money goes to the charity and to research and support. So you could start, we're trying to do a national walk, and if everyone in their own place did their own little walks, it could be quite powerful. So what do? We do a support group. We were the first, oh, sorry, just a bit more about the awareness campaigns. We've tried to host, to be present at community markets. We attend the conferences that Ali spoke about, USANS most recently, the cancer, the Australian Oncology Cancer Nursing Conference, and there's our team present. We had a table and we're handing out our brochures and sharing information. We have a national campaign which has gone up into toilets around New South Wales and now most recently in Victoria. Look out for blood in your PC or GP on the left. And then we have brochures that we have been mailing to private GPs, to public hospitals. And we want you to please send us your physical address and we will mail you our brochures and pamphlets to put up in your workplace and give to your patients, please. This is the only way we're going to raise the profile about bladder cancer and catch it early and stop patients from getting that cystectomy. If we can treat them early, we can do the local therapy, we can cure them and prevent them. But if they do need an operation, we're there to support them. We're the first national virtual support group in Australia. We started it up. We have about 25 people that meet from all over Australia, from Western Australia to Queensland, to Tasmania. We meet once a month, the last Tuesday of every month. And we meet at 7:30 and sometimes we can talk till 9:30, 10 o'clock at night. Myself and a patient, we run the group. We have a guest speaker every month. We've had the urologists, we've had oncologists, we've had pathologists. So the patients really get to be informed and educated, and then they can share their experiences with each other, and it's become a little family. And they all encourage and support each other through their various journeys, through their treatments. So that's what we do at BEAT Bladder Cancer Australia. We are supported and endorsed by a whole lot of partners, Australian College of Nursing, Cancer Nursing Society, and SUNS, which is for urology nurses, USANS, which is for urologists, surgeons, Cancer Council of Australia, they've endorsed us as well as Rare Cancer Australia. So we just want to thank you for your attention. Thank you for looking after our community. Our patients do appreciate everything you do for us. And if you want to know anything about us, please email us at any time, whether it's about a difficult case, whether a patient needs support, just email us, and we've got a large enough network in all states to be able to help you and get the answers and help that you need. Like I said, part 2 will be happening 22nd of July. So please join us again for another lovely night. And after this night, we will be sending a survey, so you can just tell us how we may improve this webinar for the next one and for future ones. We hope you invite us back again. Thank you, Chrysta. Thanks for the team at ACN. And sorry to run over time, but we hope you found this beneficial and useful and for your practice. Thank you. If there's any final questions.
No questions on the chat at the moment, but do feel free to email either info@beatbladdercanceraustralia.org.au, or if you need to get in touch with ACN, just email, pop on the ACN website, and that's where you can register for the next event as well.
Thank you. The chat function is the red bubble at the bottom with a question mark in it if there were any final questions. Again, our website, www.beatbladdercanceraustralia.org.au, or just Google BEAT Bladder Cancer Australia and we'll come up right at the top. And please send us your physical address and we will mail you those brochures. And you can even take them to your GP down the road, and if you want to put them there and tell him about us.
I've got a question on the chat.
Yep.
Are you ready?
Good. Yes.
In our day-stay clinic, we take out catheter immediately post-installation of BCG. Patients go home with instructions to hold BCG for 2 hours. What experience do presenters have with this approach?
Well, that's what I used to do back in England, actually, to be honest. Put the catheter in, put the BCG in, tell the patient to walk around, spread it around the bladder. I'll probably keep them in the clinic for half an hour, but that was the private sector there. There are often several different ways to achieve the same thing as long as it's safe.
Thank you, Professor. I hope that answers whoever's question that was. Any other questions, Chrysta?
No, just a couple of thank yous for the great information, and they look forward to coming back again.
Oh, we look forward to having them all. Professor, were you going to say something else?
No, just trying to work out why my microphone's not working. That's all.
Oh, yeah. Well, at least you know for next time. I'm glad you could join us.
I still understand it. I'm sure the other 23 people don't want to hear this, but I still can't work out why it's not.
We'll get together before the next one. We'll sort it out.
Yeah, you have you exchanged numbers now, so we'll make sure it doesn't happen again. There are no final questions from anyone else. Thank you again. Thanks to our speakers.
Thank you very much. Enjoying the webinar.
Thank you.
Thank you. Thanks to our speakers for taking the time out of your evenings. We really do appreciate that. And you also have families and lives, and you do this without fee, and we really, that means a lot.
No worries.
All right, Chrysta. Well, if there's nothing else, thank you for hosting us and for all the technical advice and setting this up for us.
That's okay, and we'll be back in a couple of weeks.
Yep. See you all then. Okay. Thank you, everyone. Have a good night.
Night.
Bye.